right, so as we mentioned before, chest pain comes from ischemia, which is decreased blood flow to an area. So ischemic heart disease involves a decreased blood flow to one or more portions of the heart, and if blood is not restored, then that tissue is going to die. And so we're going to talk about some reasons why blood flow could be blocked, some things we can do to prevent it, and then how we can treat it in a pre-hospital setting. So atherosclerosis is one of the ways that this could happen, and this is the buildup of calcium and cholesterol in the arteries that can cause occlusion of the arteries, and fatty material begins to accumulate. And so this is essentially plaque is happening here. So if you look over in the picture that's provided, you're seeing how the arteries narrowed because of the buildup of plaque. Now, there's two similar terms, atherosclerosis and arteriosclerosis. Atherosclerosis is what you're seeing right here with the plaque buildup. Arteriosclerosis is just a weakening of the vessel walls, which is preventing them from constricting and dilating the way that they should. So a loss of elasticity in the vessels. And that can happen from a variety of reasons, including prolonged untreated hypertension, which is one of the big deals there. So those two terms, atherosclerosis and arteriosclerosis, can both contribute to blockages because we're not able to dilate enough to get blood where it needs to be. A blood clot could also be a concern. And so thromboembolism, this is a blood clot floating through the blood vessels. And if that clot lodges in a coronary artery, an acute myocardial infarction or an AMI could potentially result. So some things to consider here are that blood clots can form anywhere in the body. Most often they form around joints, but really they can form anywhere. And if they dislodge or they become, lost in circulation, they could become lodged in a couple of different places. If they become lodged in the brain, you could experience a stroke. If they become lodged in the pulmonary circulation and you've got a pulmonary embolism, then you could have, chest pain, shortness of breath. You could have potential death coming from that. And then if it becomes lodged in the heart like this, if it's large enough, yes, it could result in a sudden cardiac arrest, but most often it's going to result in chest pain and ultimately a myocardial infarction. Coronary artery disease, we said, is the leading cause of death in the United States. Now, there are some risk factors for that, some controllable and some uncontrollable. So some controllable risk factors are things like diet, exercise, smoking, things that we physically can control, choices that we are making in our day-to-day lives. Things that we can't control are things like age, sex, race, and your genetic history. That's a big deal. When we start talking about things like hypertension, you could be the healthiest person. You could have been vegan for years. You could have, run 5 miles a day. But if you have a poor family history with a history of hypertension, then you might still wind up having hypertension. That might be something that you can overcome. So we need to understand what's controllable and what's uncontrollable. Acute coronary syndrome, or ACS, is caused by myocardial ischemia, and so essentially this is just chest pain, and usually chest pain falls into one of two categories. Either you're truly having a myocardial infarction or a heart attack, or we would chalk it up to angina. Now, angina, there are two types of that, and that's stable and unstable, and we're going to take a look at those moving forward in just a moment. So angina pectoris occurs when the heart's need for oxygen exceeds supply, and usually people describe this as a crushing or a squeezing pain. It does not usually lead to death or permanent heart damage, but it should be taken as a serious warning sign. If you're increasing your body's oxygen demand and you can't meet it, even if you don't have a blockage that needs, even if you're not having a heart attack right now or have a blockage that needs to be stented right now, it could mean that you've got a buildup of plaque, or you've got an issue with your vessel dilation and constriction, or you have something going on that requires treatment, because chest pain for anybody is not normal and it should be taken seriously. Now, looking at the breakdown between that stable versus unstable angina. Stable angina usually comes on with exertion. You've done something to increase your body's oxygen demand, whether you climb 3 flights of steps or you push mowed the lawn, or you've done something physically exerting. Unstable angina usually comes on at rest, so wakes you up from sleep or while you're watching TV. You've not done anything to increase your body's oxygen demand, and this is obviously more concerning. Now, Usually there is a change in as far as response and treatment too. With stable angina, this would be relieved by rest when you no longer need that amount of oxygen, or with nitroglycerin, because you can dilate those blood vessels. You've got the oxygen and blood flow that you need now, and the pain goes away. But usually unstable angina does not respond to those things. Anytime you have a patient that is complaining of chest pain, regardless of the nature, if it is cardiac related chest pain, which we'll talk about how we can kind of rule that out in just a little bit, but if this is cardiac related chest pain, we need to treat it the same way, whether we know if they're having a heart attack, if we think they're having a heart attack, if we think it's angina, doesn't matter. We want to treat every patient with chest pain the same, with the same treatment, the same protocol, as long as they are candidates for it, specifically regarding that nitroglycerin. So this pain will signal actual death of cells in the heart muscle. But again, we can't determine if this is they're actually having a heart attack or if it's just angina. So that's why we want to treat it the same every time. If these cardiac cells are dying, once they're dead, they cannot be revived. There are some clot busting or thrombolytic medications or angioplasty or stenting within the first few hours to help prevent a lot of permanent damage, and immediate transport here is essential. But once that tissue is dead, it is dead, and there's nothing that we can do to regenerate it, that you're losing heart muscle and heart function. So I want you to keep this phrase in mind, that pain is tissue death. All right, as long as the patient is having chest pain, you are possibly having tissue death, and that's a concern. So our ultimate goal is to get these patients with chest pain as pain-free as possible. Now, the signs and symptoms of myocardial infarction can be different for different people. All right. Now, this pain generally does differ from angina. It's not always due to exertion. It can be, but usually this pain comes on at rest as well, and it can last 30 minutes to several hours, whereas angina usually clears up within a few, 30 minutes, an hour or so. So people who have an extensive cardiac history will likely have tried to do something at home on their own, like take their own nitroglycerin or rest to get this pain to go away before they called 911. So that's why you might have some delay in how long the pain has been going on. These symptoms may or may not be relieved by nitroglycerin. They may have taken a lot of nitroglycerin at home before you got there, so important to ask. Also important that we ask to see it, to make sure it's still in date, to know if it was effective or not. But remember, people will complain of different things. It might be jaw pain, or it might be shoulder pain. It might be pain through to their back. It might be, I just don't feel well. It might be nausea, particularly with our women, our older population, and our diabetics who just don't feel pain the same way. So don't rule those things out. Anything that could be considered a sign of a myocardial infarction, we want to take it seriously. Now, there are 3 serious consequences of someone who is actively having an MI, and that's sudden death, cardiogenic shock, and congestive heart failure. Obviously, sudden death would be our most severe right here, and that can sometimes happen because of dysrhythmias. And so dysrhythmias are heart rhythm abnormalities, and so that could be a variety of things. It might be premature ventricular contractions, or PVCs, which are just kind of extra beats, and those could be perfusing, meaning you feel them in a pulse, or they could be non-perfusing, meaning you just see them on a cardiac monitor. The heart could be beating too fast with tachycardia. It could be beating too slow with bradycardia. It could be ventricular tachycardia with or without a pulse. If this leads to cardiac arrest and you have ventricular tachycardia without a pulse, that would be one of the rhythms that our AED would sense as shockable. That's why it's important to know what type of AED that we have available to us, how quickly we can get it on. We want to be familiar with all of this. Asystole, which is complete flatline or the absence of all heart electrical activities. Generally, this reflects a long period of ischemia. Now, this says nearly all patients will die. I disagree with that, because I think that we've come a long way in the treatments that we can provide, especially if you have ALS that are here and they're administering medications, and we can get some aggressive airway management. I don't necessarily think that everyone in asystole is going to die. Certainly, I have seen people resuscitated from asystole and cardiac arrest. But if you witness this happen, if it's just happened, likely they're in one of those shockable rhythms, either ventricular tachycardia or ventricular fibrillation, and you have a better rate of or a better success rate for resuscitation if you can get to them right away, if you can deliver a shock as quickly as possible, if you can get on that chest and start delivering compressions as quickly as possible. So just something to consider. Now, backing up and looking at cardiogenic shock, which we said was one potential thing that could come from an MI, this is usually caused by a heart attack. So thinking about to the shock chapter where we talked about cardiogenic shock, what it is and how it develops in about the 72-hour window following a MI. Not every person who has an MI will develop cardiogenic shock, but that's kind of the window where we're most concerned about it. And this happens because of that damage. Those cells died, that tissue died, the heart doesn't have the pumping power it had. And so it begins to back up. So blood is backing up into the heart, into the lungs. We're starting to see peripheral edema, meaning we're seeing swelling at the feet, the legs, the abdomen. Patient maybe had an overnight weight gain. And so now, again, blood and fluid backing up into the lungs. And so we're getting that pulmonary edema. So we want to recognize this as early as possible. See those things. See a change in the blood pressures. That's going to be an increase most likely. See a change in their weight. See a change in their peripheral edema. See a change in their lung sounds. So we're looking for these things, those signs of cardiogenic shock, as early as possible. And again, congestive heart failure is that pulmonary edema that is happening because of the cardiogenic shock. So those two things tend to go hand in hand. And again, that dependent edema is one thing we may see there. And so that's important for us to ask, have your legs always been this swollen? Is this worse than normal? And this doesn't mean that the person might not have a history of congestive heart failure. This could have been something that they've been battling for quite some time, even before the heart attack. So we kind of want to know what's normal for them and what's new as a result of this new cardiac damage. Looking at hypertensive emergencies, generally this is considered systolic pressure greater than 180, but we do want to take into consideration the patient's history and what's normal for them, because if their normal is 150, then 180 might not be that bad for them. But on the backside of things, if their normal blood pressure is 110, then 180 would be a really severe concern. So kind of looking at the patient and their history. Sudden severe headache is a common sign of a hypertensive crisis. Other common symptoms might be altered mental status. They might be seeing spots or have blurred vision. They could also begin to have pulmonary edema or peripheral edema if this has been going on for a little while. If it's left untreated, it can lead to stroke or potentially a dissecting aortic aneurysm. And we're going to take a look at the aortic aneurysm here in just a moment and talk about how does it develop and what are the differences between that and myocardial infarction chest pain. But it's important that we understand how hypertension works, how it is affecting the blood vessels. It's weakening the walls. It's creating a pocket there for blood to accumulate, and the aneurysm is beginning to develop. And so as that aneurysm continues to grow, and this could happen anywhere inside of the body, but it's really susceptible in the aorta, particularly in the abdominal portion of the aorta. And that's going to be most dangerous. You have a large blood supply there, the largest in the entire body, and you could bleed to death very quickly from a dissection from that. And hypertension, untreated hypertension, is the number one cause of that. So any patient that's having a hypertensive crisis, we want to get their history. We want to ask the appropriate questions. We want to consider ALS for treatment, and then we want to transport them to an appropriate facility. Now, depending on their history would be what's appropriate. Do we think that they are, on the verge of having a stroke based off of their symptoms? Do we need to go to a stroke-capable facility? Or is this more cardiac related? They've been battling this hypertension for a long period of time, and we need to take them to a cardiac-capable facility. Usually, facilities that are one or the other, but just something for you to consider during your assessment and when you're making these decisions. All right, I'm going to stop this portion of the video here, and I'll pick up in part 3.